We like to smile. Okay.
Hey, everybody, welcome to Dr. Tom's Tips on Tuesdays at 10. We're back with Dr. Hirsch, and we're excited about this season. So, for this season, we're going to do something a little bit different. Rather than show you individual cases, what Dr. Hirsch has prepared for us is a single case on a single patient, and it's going to be a 5-part series. So, this is part 1 of 5, and we get to see from the beginning to the entire through the process to the entire end of it. So, Dr. Hirsch, thank you so much for joining. It's awesome to see you. How are you, sir?
Rolando, good morning. Hi, everybody. Welcome back to Tom Tips. Here we go. We're getting to the end of 2022. My God, it's maybe 60 days until the start of a new year. So we're happy to be doing this again.
Outstanding. So here we go. If you could set up and frame the case for us, and then we'll get the video ready.
Okay, so this is going to be for all you newcomers, for newbies in dentistry, for guys that have been around for a short amount of time, for guys that have been around for a long time. This is a really simple case, but what's important is kind of the steps that I go through to make a case successful, and to just, besides the case being successful, make yourself successful in your own community, and in your own practice. So the case we're working on today is 50-year-old male, tooth number 31, has some sensitivity on that thing when he's eating, is sensitive to cold. We'll look at the x-rays in a few moments, but what we planned to do was a CAD/CAM restoration from start to finish in one appointment, because he didn't like to travel. He just wanted to come to the office and get something done. Didn't mind the fact that it was going to take a little bit longer. In taking a little bit longer, you have to balance that in your own practice. Do you want to spend a longer amount of time with that single patient? Do you want to spend time with that patient and move on to another room? Do you want to take impressions and send it to a laboratory? Since I don't have a high volume practice, I'm not bouncing from room to room, so I can sit down there and I can dedicate my time to this one patient. So what we did on this one is we decided to do tooth number 31, a restoration, and rather doing a full coverage crown, we decided to go with an MOD onlay. I think it's a better restoration. We have more natural tooth structure. There's less drilling. We can test the vitality later on. So that's what I like to do. Besides that, tooth number 30 next to it, I had a large composite restoration. So you can see that right there, deep composite restoration. I decided to make this ideal and do a DO onlay on tooth number 30 and an MOD onlay on tooth number 31. And as you're looking at that, you can see the worn restoration. You can see the fractured tooth on number 31. You see the little hairline crack back there. This has been bothering him for a while. There's a crack. There was no decay in this tooth. It looks like it, but it's just stained right there. And that's from a plunger cusp from up above. So what we ended up doing is we adjusted that distal lingual cusp so it wasn't going to be plunging so hard into the restoration and fracturing the tooth. And when you're doing this, look at the opposite side too, so that you can see if that same thing's happening on the other side of the mouth. You can see the large restoration on tooth number 30. The DO has a buccal composite there, so we decided to do a DO buccal onlay on that tooth. And that's the whole thing, composite restoration right there. Whether you use an isolite mouthpiece or you don't use an isolite mouthpiece, it's not the point of this whole thing. I use it because it just makes my job easier. Got a great assistant. You utilize your assistant. The point of this thing is to teach you and not to be promoting any products at all. I'm going to tell you some other products that I use in this one that make my job easier. The isolite makes my job easier. So one of the things that you might notice is that just if you're going to use the isolite, I use some KY jelly, lubricate the inside of that isolite, put a little bit on your fingertip, put it inside there. It just makes the connection so much easier. Ro, if you can back up just a bit, go back to that connecting part again. A little bit more, a little bit more, a little bit more. Back to the KY.
Oh, okay.
Okay, great. So I put a little KY jelly. There it is right there. We have isolite lubricant. The isolite lubricant works out fine. Honestly, I like the KY jelly better than the isolite lubricant. It slips on very easily. So that, you can see it's just very light fingertip pressure that I use to connect these two things together, give it a little twist. Make sure those locking barbs down below are locked in, and then spray a little water on the back of that and just gently insert it in the mouth. It takes all of 2 or 3 seconds to get it in the position that you need to use it. Fold it over, squeeze it up, and just gently put it right in there. If you need an aiming point for that, aim for the pterygomandibular raphe. Now, one of the things, thanks, Ro, one of the things you're going to notice is that cheek retractor. I only use this cheek retractor for photography. Otherwise, I'll just use my mouth mirror to move his cheek out of the way, or my finger to keep that cheek out of the way. If you want to use a cheek retractor for the prep, you can do so. It's not a bad idea, but we just use it for the photography. Back up. Here's another point that I wanted to use. Okay, so thank you. I utilize the medium mouthpiece. Go back a little bit further. Now stop right there. Nope, right where you were. Okay, hold right there. So if you look right at the medium mouthpiece, stop it right there. Perfect. You can see that the isolite mouthpiece, the medium mouthpiece, rests right up against the distal lingual gingival line angle of that tooth. It's in my way. So routinely, when I'm utilizing the isolite, or when I'm using that, and I'm working on second molars or even first molars, I will always utilize the medium DV. You might start with that because the medium DV will be out of your way more so than the medium mouthpiece, and it's trimmable. It's trimmable. Okay, so now I said, this is going to be a problem because my handpiece is going to bump into that thing. So I went to the medium DV mouthpiece. It goes farther down into the lingual vestibule, and it goes a little farther back to give you isolation. You'll see how this is. I didn't put any lubricant on this because it's already lubricated from before, but I spray it. You see, just gently put it in, aim for the pterygomandibular raphe. And now, if you look at that, you can really see there's just so much more working room where your handpiece is not going to get caught.
Yeah, it goes deeper, doesn't it?
It goes deeper into the vestibule. It just gives you more room. Stop us right there for a second. Okay, so that's the first thing is choose the right size mouthpiece if you're going to use one. If you're not going to use one, have your assistant vacuum. But the other thing that really is a boon for your practice is intraosseous injections. If you've never done that, if you've never tried it, I highly suggest that you take some time to, don't start this yet, I just want to talk for a few moments.
Sure.
I highly suggest that you take some time to learn how to do an intraosseous injection. I do the intraosseous injection and I can start immediately. I do not have to wait. If I'm doing an IA block, I don't have to wait for 2, 3, 4, 5, 10 minutes, and I never miss with this. So this will give me, intraosseously, it will give me the tooth distal and normally 2 teeth mesial. So if I was going to be working on that quadrant on 29, 30, and 31, by one intraosseous injection, I have the whole area, those 3 teeth numbed. And what I do, first of all, is I take a little 30-gauge short, which we're doing right now, and I inject right into the papilla, just a drop or two, right into the papilla. And then stop. Okay, this particular system that I use is called the Peerless system, and what it consists of is a perforator that you can see right there that goes onto your slow speed handpiece, okay, and a 27-gauge needle. It's a 27 extra short needle. I've tried to find these things so I didn't have to buy them from Peerless. I can't find them. I can't find a 27 extra short needle. So let's go back to that video. So what we're doing is that's probably 10 millimeters, 15 millimeters long. I go right back to the initial point where I was doing the injection, where I made my first little injection with my 30-gauge short. And I'm using this at about 10,000 RPMs, maybe 20,000 RPMs. And I'm going in there with water. You want to make sure you're utilizing water, and you want to make sure you're going at a very slow, stop for a second, back up. So I've got a pumping action going in and out because I've got to create a little hole that I can go back and find with my 27 gauge needle. So there it is. We put that in there, pump it in and out. It's important, if you look at the x-ray, to make sure you've got enough room between the roots of your teeth, that there's enough space to get that in there. If it's really tight, you're not going to be successful, or you're going to be really super good at getting in the right angle. So I'm pumping that up and down. Once I've done that with water, slow speed, I go and take my needle and I try and find the hole that I was putting that into. And you know what? I can't find it. And sometimes that happens. Sometimes I'll pop right in, but sometimes it can't. If I can't find the initial perforation, I go back again, and I go back into the same little bleeding point that I have and pump that in a few more times, in and out, in and out. Also, be cognizant of tissue displacement from the needle. If you're just, see, I'm having a hard time, there, I found it again. But if you're having a hard time finding that, it's because you've displaced the tissue either distally, lingually, distally, or apically, or occlusally, or mesially. So my assistant will go ahead and wash that because it's bleeding right now, and see how I just popped right in there. Okay, stop it. So I popped right in there, and what I'm going in with next is carbocaine. Carbocaine is not going to give me enough working time to do much of anything at all, except maybe a little occlusal. It's certainly not going to give me enough working time. So I'll take a little carbocaine, 3% plain. I'll inject maybe a half a cc into that, or a 1 cc. And then once I've injected that, I stop. You can keep rolling on that one, yeah.
Okay.
I stop until I've injected however much I want to utilize. And then we're going to leave the needle in the mouth, and we're going to change the anesthetic in a moment. You can inject slow, you can inject fast. I use a buffered anesthetic. My assistant will buffer that anesthetic so we don't get the sting. So there, we've taken out the carbocaine, and now we're putting in Marcaine right now. That's going to give us a long-lasting anesthetic. So Marcaine, 200,000 epinephrine. Don't need much, maybe 0.5 cc's. That's enough to get it. And then you take this out, and then you're ready to go. Always warn your patients that they may experience a little tachycardia. Always inject slowly. It's better to warn them, say, hey, you might get a little bit of a rapid heart rate, increase in your heart rate. Tell them in very simple terms. So that's normal. That will pass in a minute or two. You're going to have about 30% of your patients experience a little, rapid heartbeat. Make sure you've checked their medical history, so they're not a cardiac patient. You don't want to be injecting epinephrine intraosseously if patients are having any heart situations, any heart problems. The last thing that I did is I took a little bit of astringent, because that little bleeding point will continue to bleed unless you stop it. So I just took a little bit of astringent, put it on the area, wash it off. Make sure your patients don't taste it, because that stuff tastes wretched. And we're ready to start right now. There's no waiting for any anesthetic. We can just go ahead and go. And what we'll do is next time we'll go ahead and we'll prep this next time, so that you can really get a good feel for how we're going to prep things.
Awesome. Thank you so much for that. The context around that.
What did I miss?
Go ahead.
What did I miss?
No, that's perfect. That's perfect. Thank you for doing that. So you did your evaluation. You decided to do more than just one. I believe, if I understand correctly, in the case, originally the suggestion was to do a crown, and you decided to do an onlay and an inlay. Is that correct?
Correct.
And the logic behind that is?
The logic behind that, there's several pieces of logic behind that. One, I'm there, he's numb, it's efficient. So first of all, it's efficient, number one. Number two, it's efficient for the patient, where the patient doesn't have to come back for 2 visits or 4 visits, depending on how you do this. So there's that efficiency right there. We have an echo somewhere.
Yeah, so, well.
Is the echo on my end, or is it in your end too?
There you go. Awesome. Well, first of all, thank you for that. Next week, we're going to see you do the prep on the tooth, and then we'll see you create a restoration. 4th episode will be how you actually put it together, finish it, and deliver it. Thank you so much, Dr. Tom. Looking forward to it. Next week, everybody. Dr. Tom's tips on Tuesdays, 2 of 5, the prep of the tooth. We look forward to seeing you. Thank you, sir, so much. Appreciate it. and looking forward to seeing you next week.
Thanks, everybody. Thank you, Ro.